interpreted. I went on for so long, they all needed the bathroom. I'm only going to speak for a short time this morning, so to get the full version, you'll have to read the health gap. I'm going to just introduce the issue. Shirley introduced it by talking about the NHS, and all the fuss is about the NHS. And it seems very complicated. How are we going to manage all this increasing demand? And I think it's almost Newtonian. It's billiard balls. You've got demand, you've got funding, and then you've got quality of care outcomes. If the funding is flat, or as it is now for the NHS, declining in real terms per person, you've got to do something about demand or accept worse care, or all three are going to be in trouble. So we can't divorce the problems with the NHS from the problems of the social determinants of health, of why people are getting sick in the first place. So we've got to put them together. I've been emphasizing my whole adult life the social gradient in health, that inequalities in health are not confined to poor health for the poor. This is life expectancy by local area, defined by level of deprivation. And you can see life expectancy, it's a gradient from top to bottom, and the bottom graph is disability-free life expectancy, and it's a steeper gradient. And when we think about all policies for government, if the government wants people to work longer, they want a later retirement age, they have to do something about the social gradient in disability-free life expectancy, because people won't be fit enough to work longer unless they deal with the whole social gradient. And this is what happens if you get it wrong. This is the US compared with other countries, looking at all-cause mortality in men and women aged 45 to 54. You can see from 1990 to 2012, coming down in France, Germany, UK, Canada, Australia, Sweden, all those countries coming down, mortality, and in US Hispanics. Now look at US non-Hispanic whites, mortality going up. This is not a health service issue. The causes of death were, number one, poisonings due to drugs and alcohol. Number two, suicide. Number three, chronic liver disease, which is alcohol related. And then, of course, there's violent deaths. Anne Case and Angus Deaton, who published this, call these deaths of despair. If you don't get whole of government policies right, you end up with deaths of despair. And these have much broader issues. Researcher at Penn State University looked at quartiles of mortality from drugs, alcohol, and suicide, and the voting for Donald Trump. The higher the death rate from drugs, alcohol, and suicide, the more likely people were to vote for Donald Trump. They seem like alternatives. I'll either commit suicide or vote for Trump, who may kill the rest of us. I don't think Trump caused these deaths, but these deaths, in some sense, caused Trump, because those same areas were marked by economic distress. The higher the mortality from drugs, alcohol, and suicide, the higher the levels of economic distress. So we've got economic distress, deep dissatisfaction, voting for a snake oil salesman who lies through his teeth and will do nothing for your well-being, and deaths of despair. Are you hearing echoes of Brexit? And to try and put together the evidence on social determinants of health, I chaired the WHO Commission on Social Determinants of Health. We called our report in 2008, Closing the Gap in a Generation. And we put on the cover, unusually for a WHO publication, social injustice is killing on a grand scale. And we put empowerment at the heart of what we're trying to achieve, of individuals, of communities, and indeed of whole countries. And the kind of conceptual framework we had, the distribution of health and well-being, then material circumstances, social cohesion, psychosocial factors, behaviours, biology. And these are distributed unequally in society by education, occupation, income, gender, ethnicity, and race. And then we need to deal with the socioeconomic and political context. And that's what we mean by the social determinants of health and health inequities. And we had 3 levels of recommendations: improve daily living conditions, tackle the inequities of power, money, and resources, and measure and understand the problem and assess the impact of action. And we had, in the conditions of daily life, early child development and education, healthy places, fair employment, social protection, and universal health care. And in the inequity in power, money, and resources, number 1 was health equity in all policies. Look at all government policies for their likely impact on health equity. Good global governance, gender equity, political empowerment, market responsibility, and fair financing. And in the wake of the WHO Commission, I was invited by the British government to do the so-called Marmot review, which we published as Fair Society, Healthy Lives. We did a European review of social determinants and the health divide. We did a report for the EU on health inequalities. And in my English review, we had 6 domains of recommendations: give every child the best start in life, education and lifelong learning, employment and working conditions. Everyone should have at least the minimum income necessary for a healthy life, healthy and sustainable places and communities, and taking a social determinants approach to prevention. And we said, you need to look through the life course. And I just list the challenges in the few minutes I have. I'm not going to go through in detail, but give every child the best start in life. There are funding issues. Child poverty is on the increase. It went down through the government up to 2010 because it was a national commitment to reduce child poverty. 600,000 children were taken out of poverty, and now, as a result of government policy, explicitly, child poverty is on the increase. Education, problems with skill training, young people not in education, employment or training, and whole school approaches, problems of youth unemployment, contract workers, the gig economy, and so on. We have deep problems with the minimum income standard, minimum wages, benefit caps, green policies. Remember, we're going to be the greenest government ever. Do you remember that? Get rid of the green crap was the real, never mind. We have an absolute housing crisis that successive governments have done nothing about. How can people lead healthy lives if they can't? My children who live in London say, London's finished. If our peers can't afford to live in London, they can neither afford to rent nor buy. Where's the vibrancy of London going to continue? Young people won't be able to afford to live here because of the housing crisis. They'll all move to Coventry. I just chose that one at random. And taking a social determinants approach to prevention. So let me give you just one example. This is the long-run impact of tax and benefit reforms introduced between May 2015 and April 2019 by income decile. Look at working-age families with children. The bottom 10% will get a greater than 9% reduction in income as a result of changes to the fiscal regime, changes to tax and benefits. The second bottom decile will get a greater than 12% reduction in income. These are families with children. And then the higher your income, the less the reduction. It has been explicit government policy to be regressive, to increase the poverty levels of families with children. It was put to me by a senior politician that I'm anti-government. I'm not. I'm anti-health inequalities. I'm against any policy that's likely to have a detrimental effect on child poverty and hence on health inequalities. You remember we were being told that we were the envy of the rich world, that these policies of austerity had been working? Do you remember that? These are figures from the London School of Economics. International average real wage growth from 2007 to 15. There's Greece, got a 15% decline in real wage growth, and the United Kingdom, an 8% decline. The envy of whom? And then every other country, that's Portugal, had an increase. We're doing the worst, second worst of the rich countries. So it's not as if the policies of austerity were working to improve things for people. It was bad for all of us. Let me introduce a bit of philosophy. I know it's a bit early in the morning. I've had this discussion with economists. Consider two situations. These are mortality rates by social position. So think about the red one. The lower the social position, the higher the mortality rate. Now look at the blue one. The mortality is lower for each social group, but the improvement has been much bigger for the high social group, a bit less, and the improvement got less as you go down. Now, if you're a signed-up Rawlsian, justice as fairness, or any kind of utilitarian economist, you'd say the blue is better and fairer than the red, because everybody's got better. But inequality's got so much bigger. And I had one very big economist, he literally very big, and he said, which of these two would you prefer? And he's bigger than me. And I said, because he said, I'll tell you that all economists would go for the blue one. And I said, but inequality's got bigger. What are you, he said, some kind of naive egalitarian? Just go home, lie down and get over it. Well, we've got to have regard to improving health for everybody, so blue, in that sense, is clearly better than the red one. But we also have to have regard to inequality. That's got to be key as well. And I said to him, I want a greater array of curves to choose from. I don't want to have to choose between these two. Yes, the blue is better for everybody than the red one, except inequality's got much bigger. If we can get that much improvement for people at the top, why can't we get more improvement for people at the bottom? What are we doing wrong? I was lecturing in Dublin last evening, and a young doctor, and the question she said, and she was desperate, she said, the world's in such a terrible place. What keeps you enthusiastic? She said. I said, well, during my year as president of the World Medical Association, I took on a hard task. I tried to get doctors interested in health. And even tougher, I tried to get them interested in inequalities in health. And I said, as president of the WMA, I will not go to any meeting just because the president normally goes. So I will not go to the American Medical Association and have a glass of wine and dinner. I won't go to the Australians or the Canadians. I'm not going to do any of that. I'm only going to go where people actively want me to talk about the health inequalities agenda. So I'm going to be highly selective. And I only went to 25 places during my year. Because all of these were interested in how do we get greater health equity through action on the social determinants of health. That's why I'm enthusiastic. That's why I'm positive. Because we're winning. There's a lot of dark stuff going on in the world right now. Never mind the chaos this well-organised, sensible country that we now live in. As I was saying to Shirley, there's a fleet of unicorns going to solve the Brexit problem for us, and the ghastly stuff going on in the US and in Poland and in Hungary. There's a lot of bad stuff going on in the world. But we will win, because we're on the side of health and a fairer distribution of health. And this is a statement of the interest there is in this topic. And here's another one. You're going to hear about Coventry, a Marmot city. Lots of activity at local area. When I was doing the WHO commission, I went to the Swedish government and said, how about setting up a national commission in Sweden, like the one we had in England? And they wouldn't do it initially. But the city of Malmö in southern Sweden set up their own city-level commission, a commission for a socially sustainable Malmö. The Malmö person contacted me last year, asked if I would join a Swedish delegation to the UN in New York. She said, you're virtually Swedish. There are 10 Marmot reviews going on in Sweden. And that's not my son, that's the Minister of Health in Sweden. And then he set up a national commission. So there is now, and they've reported the national commission in Sweden. It makes sense, doesn't it? Why treat people and send them back to the conditions that made them sick? Let's treat people when they get sick, but let's address the social conditions that lead to ill health and inequalities in health in the first place. Thank you.